Hello guys, in this lesson I will discuss about herpes labialis and herpes gingivostomatitis. Herpes simplex virus is a double-stranded DNA virus that infects a variety of host tissues, and it is characterized by a lytic and latent cycle. The two closely related herpes simplex virus, which is type 1 and type 2, causes a variety of illnesses depending on the anatomic site where the infection is initiated, the immune status of the host, and whether the symptoms reflect primary or recurrent infection. Herpes simplex virus 1 and 2 are equally capable of causing initial infection at any anatomic site, but they differ in their capacity to cause recurrent infections. Herpes simplex virus 1 has a greater propensity to cause recurrent oral infection, whereas herpes simplex virus 2 has a greater chance of causing recurrence at genital area. For this reason, herpes simplex virus 1 infection typically results from contact with contaminated oral secretions, whereas herpes simplex virus type 2 infection most commonly results from anogenital contact. During primary infection, herpes simplex virus establishes latent infection in regional sensory ganglion neurons, and the virus is maintained in this latent state for the life of the host, but periodically they can reactivate and cause recurrent infection. Symptomatic recurrent infections tend to be less severe and of shorter duration than the first or primary infections. Asymptomatic recurrent infections are extremely common and cause no physical distress, but patients with these infections are contagious and they can transmit the virus to susceptible individuals. When we see herpes labialis, this is also called fever blister or cold sores, and they are the most common manifestation of recurrent herpes simplex virus type 1 infection. The most common site of herpes labialis is the vermilion border of the lip, although lesions sometimes occur on the nose, chin, cheek, or oral mucosa. And patients experience burning and tingling, itching, or pain 3 to 6 hours before the development of the herpes lesion. The lesion generally begins as a small grouping of erythematous papules that over a few hours progress to create small thin-walled vesicle. The vesicle may form shallow ulcer or become pustular, and the short-lived ulcer dries and develops a crusted scab. Complete healing without scarring occurs with re-epithelialization of the ulcerated skin, usually within 6 to 10 days. Some patients experience local lymphadenopathy, but no constitutional symptoms are there. The second is herpes gingivostomatitis. Herpes gingivostomatitis most often affects children 6 months to 5 years of age, but it is seen across all age spectrum, and it is an extremely painful condition with sudden onset, pain in the mouth, drooling, refusal to eat or drink, and a fever of up to 40 degrees Celsius. The gums become markedly swollen, and the vesicles may develop throughout the oral cavity, including the gums, lips, and the tongue, palate, tonsil, pharynx, and the perioral skin. The vesicle may be more extensively distributed than typically seen with enteroviral herpangina. This is an image of a child having herpes gingivostomatitis. During the initial phase of the illness, there might be tonsillar exudate suggestive of bacterial pharyngitis. The vesicles are generally present only a few days before progression to form shallow indurated ulcers that might be covered with a yellow-gray membrane. Tender submandibular, submaxillary, and cervical lymphadenopathy is common, and the breath may be foul-smelling as a result of overgrowth of anaerobic oral bacteria. Untreated, herpes gingivostomatitis resolves in 7 to 14 days, although the lymphadenopathy may persist for several weeks. Regarding diagnosis of herpes simplex virus infection, diagnosis of herpes simplex virus mucocutaneous infections are mainly clinical, and the mucocutaneous infection may cause moderate polymorphonicular leukocytosis on complete blood count, and confirmation of the diagnosis is by isolation of the virus or detection of viral DNA by polymerase chain reaction. The highest yield for virus cultures comes from rupturing a suspected herpetic vesicles and vigorously rubbing the base of the lesion to collect fluid and the cells. Regarding treatment, for herpes labialis, oral treatment is superior to topical antiviral therapy, and oral valcyclovir, acyclovir, famciclovir for few days shortens the duration of the episodes. Long-term daily use of oral acyclovir or valcyclovir has been used to prevent recurrence in individuals with frequent or severe recurrences. For gingivostomatitis, oral acyclovir for 7 days, started within 72 hours of onset, reduces the severity and the duration of the illness. Pain associated with swallowing may limit oral intake of infants and the children, putting them at risk for dehydration. And intake should be encouraged through the use of cold beverages, ice cream and yogurt. This is all about what I have regarding herpes labialis and herpes gingivostomatitis. Thank you for watching.